Right, good evening everybody, welcome, sorry I've got to step back a bit, am I in the shop? I have to do this. Every week I have to start like Quasimodo, you know.
So you'd think you'd have learnt by now, Roy?
The lunch pack of Notre Dame. Right, okay, is that right?
Yeah, you're
okay.
Perfect.
That's very, yes.
Well, yeah, you're looking wonderful.
Bugger it, well, just look at down there. Welcome to the, I've got a new tie. Welcome to the King's Fund for yet another in our health chat. We've got a real special guest lined up tonight, and I'll introduce him in a moment. Firstly, can I just say thank you to Salix, who look after our front of house. We're very grateful to them, and of course to IMS Maxims, who are our sponsors. And let's give our sponsors a round of applause, shall we? We've got to be very nice to sponsors these days. They're very hard to come by. And so, put your hand up if you've been to a health chat before. Yes. Oh goodness, right. We've got your fan club here as well. I think really. So it needs no more explanation or ado from me. So we'll get started because the minutes are going to be precious tonight. We've got a lot to learn and a lot to get through. So it's my great pleasure to introduce someone who I suppose introduced me really to the philosophy of management and thinking about management many years ago, and it was actually through the King's Fund that I first came across his work. So let's give a very warm health chat welcome, can we please, to Professor Henry Mintzberg. So, have you been enjoying yourself in London, or have we worked you to death?
No, I've been enjoying myself, but I want to say that I have a new tie and I refuse to wear it.
I scrubbed up because you were here. I thought, well, he'll make an effort, I should. Now look at it.
I have to wash my neck.
Should I haven't washed my neck for years. So, you did a session for us this afternoon with the IHM. How did that go?
Very well, I think, but you have to ask them.
Yeah, well, no, go on, tell us, what do you think?
No, I enjoyed it.
You can tell a lot from the audience by the quality of the questions.
Yeah. And yes, good quality of questions and interesting questions, and some sympathy, I think, to what's in the book, but enthusiasm.
Yes, because if you're here tonight, everybody on Periscope, if you were here, you get a free copy of Henry's book, but you can't because you're not here. So that'll be a lesson to you. So let's go right back. Let's go back to the beginnings. Where were the Mintzbergs from?
Well, the Mintzbergs. I was born in Montreal, but the family came. My mother was born in New York. My father was born in Poland, but he came quite young. So they were essentially Canadianized or Americanized. And I was born in Montreal. I did my basic education in Montreal.
Yeah.
Then I went on to...
What did your dad do? Was your dad a...
My dad was a manufacturer of women's dresses, which is unheard of in the Jewish community.
Oh. It's either suits or women's dresses.
He just broke new ground.
Yeah, broke some hearts. And you went off to uni, didn't you? There's an interesting story, actually, I think, about, we'll get to that later on. But where did you go to? Tell us about your early education.
Well, I did a bachelor's degree in mechanical engineering at McGill, but I specialized in the McGill Daily, the newspaper, and the McGill Carnival. I didn't do much in engineering. I kind of got through.
Why engineering?
Because I like to take motors apart and put them back together again, with a few screws left over. So I thought maybe I shouldn't practice mechanical engineering. No, I actually got a job in operational research for the Canadian National Railway. So I did that for a while. And that was modeled after the British activity, the wartime activity in operational research. Then I went off to MIT to get a master's degree, ostensibly to become a consultant, and then decided that the world was too difficult, so I stayed to get a PhD. And moved into the womb back to McGill, which I'd never left except for many years in France and US, and I've visited all over the place, but Montreal ended up being basically my roots all the time.
You're bilingual, aren't you? Speak French?
Yeah, I speak French.
Yeah. But there was a point I was reading where you sort of got to the point where you thought management theory really, the way that it was taught, and you wrote about the MBA, didn't you? Tell us about that.
Yeah, I used
to. How did you arrive at that? Because at the moment, I mean, most of us think, a master's or an MBA is probably the pinnacle of what you can do as a manager?
Yes.
So we're going to break a few hearts here. Put your hand, let's find out. Put your hand if you've got a master's or an MBA. Yes, okay, shit, right, okay. Most of the audience.
I have a master's of science, so I pretended it wasn't an MBA. Later they called it an MBA.
Yeah.
That's the pinnacle of what you can't do as a manager, essentially, especially if you think case studies have anything to do with managing. So I have deep concerns about the practice of management and the nature of the predominant form of management education, which is still a predominant form of management education.
But what made you arrive at that? Was it kind of a Damascus Road moment, or did it just sort of seep in? What
Well,
made you?
You could say, I guess, it probably started before this, but my thesis was observing 5 chief executives of different organizations, including one who ran the Massachusetts General Hospital in Boston. And maybe it was kind of seeing the reality of managing. Nobody had ever kind of done that before, and yet it was the most obvious thing to do. If you want to know what managers do, watch them, and you'll discover they don't plan, organize, coordinate, and control. Or at least those words don't fit most of what they do. And so you start to ask questions. Now, whether I'm rationalizing that or not, I suspect I had those feelings before. But basically, my view was simple, that MBA programs develop the wrong people for the wrong, in the wrong ways, with the wrong consequences. But otherwise, I have no problem with those.
Okay.
But let me just qualify that. I think MBA programs do wonderfully well at training in the management functions. They do well in finance and marketing and those kinds of things. They don't do well in the practice of managing, because you can't take people, I'm talking about regular MBA programs for young people. Management cannot be learned in a classroom any more than swimming can be learned in a classroom. You have to do it. And then the best education is to take people who have done it and develop them based on their own experience and give them a chance to reflect on that experience, share it with each other, and learn from it. And that's the kind of programs we eventually created in place of regular MBA programs.
There's I mean, it is interesting because, I mean, we've gone through a very difficult time here with the health service. Partly it was about a political reorganisation that's really gone badly wrong, and partly because of austerity, right. Trying to run Rolls-Royce service on bicycle money, and managers are put in a very difficult position to do that. Yeah. And it seems to me anyway that this is such a special time to be managing. It's such a difficult and challenging time to be managing, that almost everything we know about managing in the past, which is what essentially study is all about, it does not equip us for what we're trying to do now.
Yeah, I wouldn't quite put it that way. I would say it's gotten worse. But I think the fundamental issues were there all along. I tend to distinguish what I call engaged management or engaging management from remote control managing. Remote control managing is reading numbers and financial reports and so on, and deeming things like we didn't make our numbers on the expectations of the stock market, so we'll fire 5,000 people. Well, my granddaughter, who's 12, could do that. She could deem 5,000 people out the door. It doesn't take any cleverness to cut costs on paper. It takes a hell of a lot of ingenuity to be able to cut costs without killing the system, which of course the senior ranks tend to dump that on lower managers. One person called a heart transplant surgeon called the head of the hospital and said, I have a patient, I have a heart, I have an operating room, I have no budget. What should I do? Now, who's going to say no? On the other hand, who gets blamed if they say yes? And that's the kind of thing we have in the healthcare system.
Well, and we've had it here. There's been a television program here where one of our big teaching hospitals opened its doors, and we're very frank, it was a fly on the wall type documentary. And there was a surgeon who wanted to do a very important and major operation on a patient. who'd been let down on 2 or 3 previous occasions. They sort of, you know, waltzed them up the aisle to get the operation, and then decided they couldn't do it, and there were no beds. The problem was no beds, and I remember that one bit of the television program where he said, you know, I'm probably, you know, he didn't say this in a conceited way. He was saying, you know, I'm probably one of the most skilled people at what I can do in this country, and I'm standing around because no one can find me a bed.
Yeah, and that's not uncommon. I had open heart surgery a year and a bit ago, and they couldn't take me on Friday, and the whole team came in on Saturday. Now, was that because it was me? Or,
I think they were terrified.
But I think no matter who it is, unless it's kind of the head, the minister or something, for the whole team to come in on Saturdays.
Yeah. Well, we do 7-day working here, of course. Very safely, very safely. Yeah.
But you know, I think the root of the problem is not within the healthcare system. The root of the problem, and that's what I start my book, Managing the Myths of Healthcare, but I don't know if you want to get to that eventually, but the root of the problem is that healthcare is not, this is one of the main myths, healthcare is not failing, it's succeeding. It's succeeding dramatically because of open heart surgery and all kinds of other things. Of course, that's not new, but other things, you know, one-day stent things are new and so on and so forth, or newish, the fact they do it so short now. And physicians, and to some extent pharmaceutical companies less justifiably, are coming out price-wise, are coming up with wonderful ways of extending our lives expensively, and we don't want to pay for them. You see, the sick are a lobby group for pulling out all the stops and spending as much as possible to save me, and the well are lobby groups for not spending anything because after all we're going to live forever. And so when that meets people who don't want to pay taxes with people who do want to get proper health care, you get these problems of having to cut costs. But how do you cut costs when the costs are going up, partly because people are getting older, but also partly because of
well, is it
development?
about putting a rationale behind the use of resources, not rationing resources, but using a rationale to use the resources?
Well, it depends what form that takes. I mean, in a way, you can answer that both ways. You could say, sure, I mean, that's what we have to do. On the other hand, how do we do that and maintain quality of service?
Well, what we've tried to do here is the National Institute for Health and Clinical Excellence. NICE, I'm sure you're familiar with that. And they run the rule over mainly new drugs, mainly, although they do other things. And they have a thing called a quality adjusted life year, which is a calculation that says if it's cost more than 30 grand for a year's extra life, we won't pay for it. So it's pretty rough and ready. I mean, I've described it pretty brutally. It's more finesse than that. But if anybody from NICE is going to sue me, but it's more or less that they set a threshold and they say after that we aren't going to do it. And then of course it takes us into territory. Now we've got very expensive cancer drugs, and people say, hey, you know, I want you to spend another 50,000 so that I can live for an extra 3 months.
Yeah, yeah. Well, the first question
but that
is
takes into, sorry, the point I wanted to make, Henry, was that it takes us into a moral and ethical dilemma for managers, doesn't it? It takes us beyond management.
Because we're not prepared to pay for what we want. Essentially, that's the issue.
So do you think we should pay for everything?
I'm not necessarily saying we should pay for everything, but I'm saying we have to face the fact that because of globalization, for example, governments are being squeezed to cut taxes every which way. And as long as taxes keep getting cut, we're not going to pay for what we want. The other thing, of course, is that $50,000 medication. What is that costing the pharmaceutical companies to produce? We've got to look at that carefully, too. That's the part that could be fixed right away. A patent is a monopoly. A patent is a state-granted monopoly. And certainly companies need profit to produce those things, but do they need the obscene profits that they're often getting? We have to face that too.
To argue their case, they would say, look, for every molecule that turns into a blockbuster, they have to go through the palaver of evaluating 50 or 60. They waste millions on trying to see whether, because it's more or less it's a process of serendipity, isn't it, to find something that works. So they say we've got all the costs of developing a drug that we can take through the regulatory process, but we can only patent a drug for 20 years where I can copyright a popular song for 50 years. maybe it's not the pharmaceutical company's problem, maybe it's the regulators who we could say, well, why can't we license a drug for 30 years or 40 years so they can amortize their investment over a longer period?
Yeah, I did an article called Patent Nonsense
I know.
that went through each of those arguments. It used to be $800 million to develop a new drug. Last I saw was $1.2 billion. Those numbers have been proved to be outright lies. And it leaves aside all the researchers who are developing better forms of Viagra and so on. Or Me Too drugs or all kinds of other things.
Nothing wrong with better Viagra.
The three most significant pharmaceutical developments in the 20th century arguably were penicillin or antibiotics, insulin, and Salk vaccine. They all came out of not-for-profit laboratories, and Salk refused to patent the Salk vaccine because he wanted it available for everybody. Okay, so it doesn't have to be the way it is, but we don't have to beat up on the the more we do the better, but we don't have to beat up on the pharmaceutical companies.
But it gives us, what I'm sort of moving towards is the moral and ethical dilemmas that managers face, because it moves us beyond the mechanism of being a manager. So, if you, and I've done it years ago when I was the chairman of a health authority, where a new drug would come. It was before NICE. We'd sit down with a medical committee and we'd decide whether or not our particular health authority could afford it or would want to do it.
Yeah.
And there were, I don't know how many health authorities there were then, but so this health authority would say yes, that one would say no, this one would say maybe, and you got this horrible postcode thing. But it was I hated having to do that. It was a really difficult question to answer. And then when NICE came along, the National Institute for Health and Clinical Excellence, when that came along, the industry created holy hell over it. But now they quite like the idea of being approved by NICE, and it's led the way really in Europe. I mean, NICE now, it's not a lot of people know it, but NICE have a big European division now where they sell their technologies and techniques to other European countries. I guess we're not going to do that anymore, but it's putting a rationale behind the use of resources. I don't know how we can manage in the future where demand gets bigger, costs get higher. What the hell does a manager do?
Well, sticking to pharmaceutical just for a minute.
Yeah. It could be devices as well.
The price, the pricing is kind of a starting point for them, but cost has to be a starting point, and reasonable profits have to be a starting point. Of course, they need profits, and of course, they need profits to fund research. The question is how much. And the question is, where do you start with pricing? I think the idea that anybody, anywhere, dies for want of a drug that could be affordable is abhorrent. It's abhorrent. And it's a reflection on how perverse our society has become. That people die for want, not of pharmaceuticals that cost a fortune, in production, but pharmaceuticals that could be available if pharmaceutical companies were making reasonable profits. And the people are going to look back and say, what was going on in your world? That people were dying for want of these pharmaceuticals. You've seen the cases where somebody triples the cost or multiplies by 10 the cost of an existing pharmaceutical. Obviously the price, and obviously the cost hasn't gone up by a factor.
That's usually where something's been generic, and then it gets sold on rebadged and the price goes up. We have, I don't know what it's like in Canada, we have a system here where prices are capped, and
in Canada too, but not enough.
No, so you'd cap them low?
Cap them at some function of cost of production, taking into account cost of research without using their figures.
So you'd have like open book accounting?
You'd have some way to know roughly what the cost of something like that was, some reasonable way of knowing, and what the cost of production is.
The problem we've got here, of course, is that we're only 3% of the European market. Now, we all think the NHS is very important, and it is, and it is much admired globally. And a lot of the major pharmaceutical companies come here. They come here because we speak English, because Heathrow is a good hub, and it's safe to bring your family, and we've got Waitrose. I mean, what is there not to like for an American? This is nirvana here. But the problem with that is they come here and they can launch across Europe and we hang on to them, their coattails, because we're 3%. Now we're coming out of the European Union. My guess is that most of them will go to Frankfurt. In fact, you can't rent office space in Frankfurt now because it's all gone already, and they'll go. And because we're such a small part of the market, we won't get launch of new product here at all. But you get, I mean, you're fortunate in Canada because they see the Canadian and the American market as one market, don't they? Pharmaceutical companies will regard that as an accessible market.
Yeah, I mean, we have more regulation than the Americans do, especially in their Medicare, especially in their government-funded program. You know, a bribed Congress, essentially, bribery is legal in the United States in terms of political donations. A bribed Congress makes sure that they can't negotiate with the pharmaceutical companies, just start grading that. We don't do that, but we don't control it nearly enough. In terms of, as I say, in terms of cost.
That's interesting. Okay, let's get back to management. You do a great lecture with the triangle, don't you? With ACT at the top. Tell us about that. I love that.
You're talking about art, craft, science?
Yeah, yeah. So this is. I thought this was really clever.
The table and all that. It's actually very simple, and it's in. I think it's in the new book too, Managing the Mystery of Healthcare. But it may be. It's available in other places. Beverly Patwell and I developed this simple instrument where you had 3 rows, and you picked one of each 3 along 10 different rows. 3 columns, 10 rows. So one might be something like analytical, intuitive, God knows what the third one was, or the last one is, I can't forget, I can't even remember the words, but they're all words that relate to basically art view, craft view, and science view, and people circle whichever one on each one, and then they add them up at the bottom, and we plot it on a triangle to see whether you're closer to art, more insightful, intuitive, visionary kind of management, or craft, which is more experience-based and rooted, or science or analysis, which is more numbers-oriented, and so on. And people plot themselves on there, and then we get them to look at their teams, or we get them to have other people do it for them to see if they're judging themselves correctly, and we get them to do teams, and we argue that nobody can be perfectly balanced. People tilt, and teams tend to work well when there's some balance across those 3, so that you don't get everybody in the analytical corner, which too many organizations these days are at senior management levels, or too many at the art level. If you've got an entrepreneur running the place, he or she's probably going to be way at the top in art. So maybe they need to surround themselves with more craft-like, experience-based people and more analytic, science-based people and so on. So it's a nice way to kind of see yourself, see your management style and so on.
Do you think this, I mean, what is it about the style of management that works? I'm more and more now, I mean, I just see the world really, I suppose, from the UK NHS point of view, but more and more it seems that we are in the hands of administrators and not managers. That's the data thing. I mean, we're obsessing on data. We don't use enough of it, to be honest, in my view, but we're using, you know, we've got the administrator and we've got the leader, and one wonders really, what is the future of the manager?
Well, I'm not a fan of this distinction that somehow leaders do the important things and managers, to use a medical term, do the scut work, you know, sort of clean up the blood after the operation. And I don't believe that at all. I think it's a dangerous distinction. Nobody wants to be managed by somebody who doesn't lead. You don't want a manager who has no leadership capabilities at all. Well, why should you have a leader who has no management capabilities? They don't know what's going on, which is what's going on in the White House right now.
I know what's going on. I watch Twitter.
Well, he's not, ironically, because it's not usually characteristic of entrepreneurs who are usually very hands-on, but he's hands-off. So we need that kind of, we need leaders who are managers and managers who are leaders. And we need those combined, and the best people combine them. We also need to step back from remote control managing, which is you sit at the top of a hierarchy. The very term top management, like top of what? top of the building, unless you're in a hospital, then you're probably on the main floor so you can get a quick getaway. But usually it's top of the building, top of the salary scale. But in the English usage, if you see yourself on top of the organization, does that enable you to be on top of what's going on in the organization? If the organization is down there and for everybody else, you're up there, what an awful metaphor. It's almost as bad as human resources, which is the worst metaphor. You know, I'm not a human resource, I'm a human being. And top management is an awful metaphor, but of course, that's the image. Too often created in MBA programs, too, that somehow were superior. And so managers have to get on the ground and see what's going on. I do blogs, I do bi-weekly blogs now, and one of them is called Managing Scrambled Eggs, and I'm doing a collection of them as a book, and it's about the head of the biggest airline in the world, and one time I took a flight on that airline, and I said to the flight attendant, like, I've eaten bad things on airplanes, but never these scrambled eggs. I've never eaten anything as bad in my life. And she said, I know we keep telling them, they won't listen. Now, if you're running a funeral home, it's hard to communicate with your customers. but if you're running an airline, somebody told me a story about the chief executive of Eastern Airlines, which went bankrupt not long after, although it's the biggest one in the world. And he was late for a plane, and they bumped somebody in first class so he could sit in first class. Well, there you got your answer. He doesn't even know where economy is. He'd probably have to ask if he had to go into economy, which way is economy. He's rewarding himself by keeping himself away from most of his customers. If he ate those scrambled eggs, they would have been gone in a day. And that's what I mean by remote control management, that somehow we distance ourselves from, and in healthcare, I've seen a good example, but I've seen abhorrent examples of people talking generalities about risk. And I have a theory of risk. It's this, read the story in the book. It's an NHS story. You know, I have a theory of risk, and it was like bizarre. It was bizarre. This was a conversation about purchasers and providers in the early days of that, and nobody knew what was going on, and yet everybody's trying to convince everybody else they knew what was going on, and we have too much of it.
Yeah. Dare I mention his name, Tom Peters? I mean, Tom talks a lot about middle managers, doesn't he? And stripping out middle managers.
Well,
he's pretty brutal about them.
Yeah, but if you read In Search of Excellence, he's brutal about middle managers who he sees as disconnected to. But if you read Tom is about hands-on management.
He is. And management by, his phrase was management by walking about, wasn't it?
Yeah, exactly.
It came from him.
He used to talk about a guy who owned a garbage company in San Francisco, had a garbage truck on his desk. And he said to Tom, you know why we're so successful? Because I love garbage. Okay, well, that's good. Yeah. That's good. If you're going to run a garbage company, you should love garbage, or at least getting rid of it. And that's why entrepreneurs, unlike the White House entrepreneurs, that's why entrepreneurs are usually so successful, because they're right down on the ground. If it's retailing, they're in their stores. They know what's going on.
I read your piece about you can't run America like a business.
Yeah.
Tell us about that. Anybody else read that? It's a really good piece. Yeah.
That was in my blog.
Where do you write your stuff? I was always interested to know where you write your stuff.
Physically?
Yeah.
At home.
Yeah.
It's all at home.
Yeah.
I have a,
sit at a laptop and
yeah. I sometimes a laptop if it's prepared. Other times I handwrite. My secretary types it.
Really?
Yeah. Often. And then
wow.
And then I correct it on the laptop.
Yeah.
Please don't start getting any ideas.
So
I write my stuff on an iPad in the back of a taxi or a pub or something.
Yeah, I edit on the laptop and so on. But I do both these days. But all my books have been handwritten.
Really?
All my books have been handwritten. Yeah. Sometimes as much as not sometimes, all the time, at least 5 times, and sometimes much. This book went through 10 drafts, I would estimate. When I say a draft, the 9th draft was scribbled all over.
Really?
All over. Yeah. So I physically write by hand. But the piece, it was written. There's a version of it at Harvard Business review.org.
That's where I read it.
Oh, the better one is on my blog.
Yeah.
Because they edited it in ways that were, I think, appropriate for them, but I had more fun with the blog. The blog is just mintzberg.org/blog, or at Twitter 141, because I couldn't put at Twitter 140 plus, so I put 141, and that was this 140 characters on Twitter, so I put 141. And I call it a twog because it's from tweet to blog. I almost only tweet to the blog, what's on the blog.
Well, you drive traffic to your blog. It's very sensible.
Yeah, that's what I do. So that one opens by saying, "Dear Mr. President, I have some unfortunate news for you. America is not suffering from too much government; it's suffering from too much business all over government." And I was making the point that I made in the previous book called Rebalancing Society, that we're out of whack as a society. I mentioned that before a little bit with regard to the balance between government, and private industry and so on and so forth.
I mean, how do you see, I mean, what's the question I want to ask? Where does this end up? We're in the middle of a general election fiasco, really. No one wants, we got one party that's kept the health service in austerity, really. And now we've got a very left-wing leader of our Labour Party who's had his stuff leaked today, and he's talking about putting up taxes. We've got the Liberal Democrats who are talking about hypothecating a tax to uplift just for health. And hitherto, the political theory has always been people won't vote for tax rises. Mm-hmm. So it'll be interesting to see what does happen and the extent to which we can persuade people that they have to pay for their health care.
Yes.
Now, do we do that through taxation, or do we do that through people having to pay for their health care through insurance, or attach a value to it that they can see?
Well, in Canada, the latter is an absolute taboo. Canadians revere Medicare. Medicare is across the board. It's much more extensive than your NHS coverage.
Is it?
Yeah, because I shouldn't say there's no private sector alongside public, and I can't say there's no choosing to do it tomorrow privately or next year publicly. There's some of that creeping in, but not much.
What percent of GDP do you put in Canada?
I think 11 and a half.
Yeah, I mean, that was when we were on the European average and the health service was working better. We were just under 9%.
Yeah.
Now we're at 6.3.
I know, but the question is what's behind the what are the consequences of that? As I said, it's easy. It's not easy to do cost cutting, but it's easy to deem cost cutting.
Yeah,
it's easy to reorganize. That's why the NHS is always reorganizing, because give me a sheet of paper, I'll reorganize. I mean, move them there and that there and her there and then there, and change this title, change that title. I use a little kind of amusing thing. I say this is an organization, and I put up a chart, regular chart, and it says top management, middle management, bottom management. And then I say, of course you call it bottom management, don't you? And nobody calls it bottom management. I say, well, then why do you call it top management if you don't call it bottom management? And then I say, now I'm going to show you reorganization. So the first one says organization, second one says reorganization. It's exactly the same thing, because nobody's reorganized their head. They just move some people around, change some title. It's so easy to do. That's why we do it all the time. Same like the cabinet. The prime minister, who why do the British prime ministers always think they're president? They're not president. She has a mandate. If you understand the parliamentary system, her mandate comes from her constituency. That's her mandate. She doesn't get a mandate as a prime minister. She gets a mandate as a member of parliament. And the party decides, ostensibly, who should be prime minister. They did decide that Margaret Thatcher had enough of being prime minister. But anyway, but anyway, forget where I was. But in Canada, Trudeau campaigned on the basis of partly a different view of taxation, a different view of, he had the guts to do that, and a different view of government deficits. He said we're going to have deficits. And the people who are honest you know, can get away with things. The interesting thing about your election is in many cases people have punished, you know, leaders who started early elections when it was unnecessary. And they said, why are you doing this? In Canada we had a case of that where somebody called an early election and was punished for it and lost office. I mean, she knew what she was facing in the way of competition, I guess.
Well, I think the reason for the election here is that it's not really that we need an election now. She just needs a big majority for what's going to happen. Because what will happen is we're coming out of the European Union, it's going to be a bumpy ride, and she wants a comfortable majority to see her through the House of Commons with what is going to be a very bumpy ride. I mean, and you know, we've got a deal now where we've said we'll come out of the European Union, and we've got no deal to say on what terms we're going to come out. So it's just a done deal. We've got to put up with whatever she can negotiate. She's not going to be able to negotiate very much because, you know, they want us out, and that'll be the end of it.
They're not in a very negotiating mood.
No.
Yeah, and Cameron, I think that ranks with Iraq and Blair in monumental stupidity. And it's amazing how we get people. I mean, you've got 65 million people, I think, in the UK, or Great Britain. I always mix up which is which, but anyway, I think UK.
It's okay.
Surely you can find a few really good people. You know, surely it's better than Donald Trump in all of the United States.
It's not politics is not a job you want to do because you're so open to press scrutiny and criticism, and you know, anybody who's any good will go off and go into business, run a business, make some money, have a great family and a good life. I mean, why would you want to do politics? Well,
Trudeau is doing it very well.
But it's interesting because his dad was the premier, wasn't he? And he's got he's got the ethos of vocation and public service that runs through his family, and it was, you know, that's what you do, I suppose.
But he's actually very different from his father. Trudeau, Pierre-Elliott was a technocrat. In terms of, he was great for Canadian unity and not Quebec, but the rest of the country and some of the things he did. Very technocratic, like remote control management, and very numbers oriented in how he managed and so on. As was Blair.
Well, Blair, I think, changed the whole party. He shifted the party to the middle ground, which is where the votes are.
Yes.
And Mrs. Thatcher had a vision for Britain, and so Mrs. Thatcher came in, the government ran the airlines. Can you imagine that? You know, and she said, no, that should be done by a company. So she changed the whole ethos. Let's get back to management. It's interesting to talk to you. We've gone off on a tangent, but it was interesting anyway. So coming back to managers, I mean, what I find when I travel around the country and I meet managers is that now they don't manage, really. Most people just kind of administrate and try and do a huge amount more work for a lot less money. It's much more constrained. We have regulators here, NHS improvement, which is a euphemism for the Gestapo who will come and beat you up. We've got the Care Quality Commission, which is a euphemism for useless, because you can't talk to us about quality. Because I think from what I've read of your immense works, is I think we're on the same page on the role of inspection in quality.
Yeah, and measurement. You know, this idea of a balanced scorecard where everything that matters can be measured and equally, and this idea that somehow children in education, we can measure how much they learn. You're all here, you're all going to go home. So please, at the door, leave some firm indication of what you learned in this time you were here. I'd like to know what you learned. If you can measure that, good for you. I've never seen anybody able to measure learning of any kind. Don't tell me an IQ test is a measure of learning. And I've never seen anybody able to measure what a child, or an adult for that matter, learns. You read the book, and you might say it's wonderful and never do anything with it, or you might say it's awful and change your life because of something you didn't realize you read in the book. We can't measure so many of the good things. We can measure costs a lot easier than we can measure benefits. Quality is one of the benefits, or main criterion for benefits. very hard to measure quality.
You measure poor quality, can't you, by having to do things again, or waste, or...
You can measure certain things, certain aspects of it, but a physician sees a patient. We're told that from one study that GPs average about 23 seconds before they interrupt their patients and never give them a chance to talk again. There was one study. It was better. It used to be 17 seconds, now 23 seconds. So we're told about that, and then a GP comes along and listens to a patient at a 23-second mark, says, this is really interesting and this is really difficult. I better give this patient another 7 minutes. You know, oh my God, you can't do that. I mean, you're going to throw everything to the wind. After all, we've got to measure, and you've got to see X patients, and if you spend 7.5 minutes with this patient, you're going to have to spend 21 seconds with the next patient, and it's all just a lot of nonsense. And it's costly. It's costly because if you interrupt the patient in 23 seconds because you've only got 2 minutes to do what you're doing or whatever you're supposed to be doing, then if that patient has something that takes more than 23 seconds to explain, they'll be back. But they'll be back much worse, possibly. So if you caught it now, you could give them a new diet and a new ways to deal with their cholesterol, and they won't be back for a stent in 6 months or 6 years or whatever it is. But how do you measure that? How do you measure the fact that they're not coming back, or they're going to come back much later? We can't measure that. But what we can measure is how much time they spend with patients. So we manage that stuff and screw up the whole system.
Yeah.
And of course you can say it's easy for me, I'm just sitting here, I don't have to manage the system. But then I come back to the basic point in the book, which is the problem is not in healthcare. Healthcare, where it focuses its attention, which is on more acute treatments, more than milder treatments, which often get ignored, more than health promotion, and more than disease prevention, but on treatment, it's doing amazingly well. It's doing fabulously well, and it's expensive, and we don't want to pay for it. That's the problem. And so what do? We intervene in all kinds of ways administratively, by cutting costs, by telling physicians they have to see people in so many minutes, by doing this, by doing that. And it's also disconnected from the reality of service on the ground. So what do? At least you can get the people who need to worry about costs in touch with the people who are incurring the costs, namely the physicians, the nurses, and others, and work together to figure it out. Day surgeries came out of this country, okay? It didn't come from people in offices, it came from physicians who had that idea. It's probably the most astounding reduction in cost, not at the expense of quality, but probably improvement in quality, that we've had in healthcare in decades. This came out of people on the ground. So it's not a question of not having to cut costs, it's a question of doing it and engaging the very people who know what's going on the ground. And by the way, that can be the nurses more often than the physicians. Often they're more in touch with
well, we run a thing called the Academy of Fabulous Stuff, which is positive deviance, really, where common problems are solved uncommonly by common people, and we get 30, 40 fantastic ideas a week, and they all come from the front line.
Yeah, exactly. There's a wonderful story from Kaiser Permanente where they discovered that it's not that they discovered, but they were concerned with nurses picking the wrong medications, which could be very dangerous. So they did a study, and I think they started to color the usual thing, put different colors or whatever. And the nurses said, this doesn't get to it. So they studied it in one hospital. And what they discovered was the problem came about when people were interrupted. Someone would say, how about the patient in this bed, and so on and so forth. And when they went back, they picked the wrong med. So they put things on their backs, something like that, saying, picking meds do not interrupt, or something to that effect, okay? That's an example.
Yeah, we had that there. Now, I've also discovered that you are delightfully eccentric in your hobby. I don't know how we describe this, but you collect beaver statues. Now, there is another connotation to that, which we won't go, but tell us about your beaver statues. You've got to see this on YouTube, really. It's fascinating.
It's only England that it's eccentric. Of course, all Canadians do this.
I don't think so.
You don't get your passport unless you collect beaver sculptures. I call them beaver sculptures.
Come on, you're mad. let's get to it. You're mad.
If that's mad, it's really fun. Mad is fun. We have a house on a lake. Most of them come from that lake. It's actually called La Castor, which means beaver in French. And most of them are picked there. And I just pick what the beavers leave behind. Not off the dams or the lodges, that's theirs, but what's floating or left on land or whatever it is. And some of the images, they're astounding. It's not like
it's the ones on your website. They look like they've come from some very real avant-garde gallery somewhere in the West End, and it says, you know,
yeah.
£5,000 to the bottom. And they really are exciting, aren't they?
Yeah, they're gorgeous. They're gorgeous, and I think whatever it is, the Tate Gallery or whatever. I mean, all their shows are work by mammals. So why not beavers?
Excellent. Right, let's have some questions. Who's got some thoughts? Who would like to ask a question? Let's fire away. Where are we? What have we got? I can't believe you stunned us all into silence. Right. Where's Sam Jones?
I'm going to march over to whoever's talking so I can hear you well enough.
Okay, come on. Let's have. Yes, sir. Right at the back. Could you shout out nice and loud?
Yeah, I've got one. I agree with everything I've heard. And I agree, Henry, we do have a problem with remote leadership, or leadership by remote control, as you call it. Roy, I agree with what you say. We don't have leaders. We have people in leadership positions who masquerade as leaders, but they're really technocratic administrators. My question is, why is that the case? Now, in my professional experience, I've worked in across the NHS and in social care. I think it really boils down to two things for me. First one is the wrong perspective is taken on the work. So folk may find this difficult to comprehend, but at senior levels of the NHS, it really isn't about the patient, never mind the person. It's about, am I doing too much activity, or am I doing too less? And is it costing, or am I getting a nice surplus? And why do I think that? Is because actually I think at the top level, we have a leadership capability issue, which is, it comes back to your points that you were mentioning earlier. If you were to drop a senior leader into a frontline area, whether it be sort out a waiting time problem in a clinic, understand why a personal budget isn't working for someone in social care, or resolve the problems in accident and emergency, I guarantee you they wouldn't know what to do or where to start. Your comments, please.
Henry, would you mind coming back to the front? Because we can get the answer for people on YouTube. Yeah. Can you crystallise the question?
Can I crystallise the question?
And then just answer it, that's all.
Well, the question is kind of why do we get this kind of management and the disconnection basically at senior levels, where you're at the top and you're at the so-called top and you're removed from that. I also think it's what too much management training has been about. A case study method doesn't say, when you do a case in a Harvard classroom, you don't know the company, you don't know the people, you don't know the products, you didn't even hear of the company probably before yesterday, you read 10 pages last night and you're supposed to pronounce on that. That creates a George W. Bush kind of presidency. People who is a Harvard MBA. And so partly it's how we view management, that somehow it's some disconnected thing, and yet when the stories we revere of managers are the ones who get down on the ground, see what's going on, and if you're running a supermarket chain, Waitrose or whatever, with hundreds of stores, you don't necessarily have to go into hundreds of stores, but if you go into a few stores, you get an idea of how people are reacting, what they're seeing, and so on and so forth. We were having breakfast this morning, and the food was kind of, it was a nice place with nice design and nice products and all that, except the sandwiches that were heated were cold. And I thought, it's more about design than it is about execution. That in the headquarters you can design these nice menus and decide what they're going to be, and they sound terrific. And the fact that they're screwing up by delivering them cold is not part of your knowledge, because you're not down there eating the sandwiches, and that's too common. That's too common. Your other inference is hierarchy. The very fact that I mentioned this before, but the very fact that you're top management means you're disconnected from what's going on at the bottom. But it shouldn't be top and bottom, it just should be the operations, the reality. The reality is out there, and you've got to connect with the reality. And no matter how senior you are, you don't have to do everything and be everywhere. You just have to get down and engage with the actual activities and experience them. And then people will follow your example. And, you know, and start to say, there's a famous bank president in Montreal, in Canada, the head of the Royal Bank of Canada, the biggest bank. And he was famous for calling into headquarters on the way to the airport and saying there's an ATM machine at such and such a corner that's not working. And it's not because he's supposed to report every ATM machine, it's because everybody is supposed to report a non-working ATM machine. And he was simply setting an example, not consciously. He was calling because it wasn't working. But the fact is he was chairman and he didn't think he was above that. And that sends a message to everybody.
Do you know, your question really takes us into a really interesting other set of thinking, I think. I mean, I always say that leaders always hire people who are better than them, stand back and take the credit. If you hire people worse than you, you step forward and take the blame. So leaders always hire people better than them, step back and take the credit. That's the first thing. And leaders create the time and space for good people to do great things. So I'll come to you in a minute, and you. And leaders create that environment where people can flourish.
Yeah.
But the environment we have now, which is what I think was the sort of the undercurrent of your story, was that we have an environment now which is so regulated and so squeezed. We're almost squeezing out the ability to manage. We just are focusing on delivery, and there's a huge difference between delivering, managing, and leading.
Yeah, I would just challenge one little bit of that, which is they shouldn't be taking the credit, because everybody should be taking the credit.
It's the obverse of taking the blame, which is the point of the story.
It's a good way of phrasing it, but I think taking the credit could be part of the problem.
The sharing.
I'm not a fan of leadership. I recognize leadership makes a huge difference, no question. And there are leaders who just really...
Can you teach it?
No, I don't think you can teach it.
Sandy has to teach it.
Well, they teach a particular kind of it. I can tell you about an organization in this city that has been screwed up royally by one military officer after another trying to manage something that's not military. But that's...
Horses for courses.
That's a different story.
Horses for the cavalry.
But I think communityship is much more important than leadership. I kind of coined the term, you know, we've got leadership and citizenship and ownership, and we should have communityship. And I simply say the word, nobody should be allowed to utter the word leadership without uttering the word communityship in the same sense.
Well, creating a community in an organization is interesting, because one of the things that we do know here is that the best performing trusts, best performing hospitals, are the hospitals that have had their leaders in place for the longest time. There's a direct correlation. Thank you. Correlation. It's easy for you to say. There's a direct correlation between length of service of the leader, in inverted commas, and the success of the organization.
Yeah, I can guess that. Probably for several reasons. The very fact that they've stayed that long, chosen to stay that long, been able to stay that long.
Know everybody, do get out and about.
Okay.
We've excited a couple of questions. There's a couple here, and Jenny, I'll come to you, but I'm going to go to Sam Jones first. Would you mind standing up, Sam? And shouting. No.
I'm going to stand near you, sorry.
I'm just not sure I recognise...
Henry wants to be near you while you speak.
I'm just not sure I recognise what you were describing, and I think we have to be very careful.
It's a question, Jim.
I am.
Well, leave the guy alone. He's paid for a ticket. Be nice to him.
Let me finish.
Yeah,
I
go
have
on.
to finish my sentence.
Go on, get on.
I haven't started it. So I think we need to be very careful that we don't stereotype managers, clinicians, frontline. I absolutely agree with what you were saying around making sure people work as a team and you understand what's going on in your organisation. So my question to you, thank you Roy, was how do we make sure we break down the stereotypes and ensure that people truly do work together? I also don't recognise, sorry Roy, what Roy describes as people who are not managing. Day in and day out, we have amazing people across our country doing it. So my question to you is, how do we make sure that we fundamentally work together to support the people who use our services?
Yeah. You know, clinicians
Would you mind coming back so we can get you on camera?
Clinicians don't like, many clinicians don't like hierarchies of authority, but they're slaves to their own hierarchies of status. You know, interns and residents and consultants and, you know, big researchers and all that. They're prisoners of that. There was a guy running a geriatrics ward in a Montreal hospital, running it very well for a long time. And he said his best diagnostician was a physiotherapist. And that's the kind of attitude that's necessary, where everybody has something to contribute and nobody gets put down. And by the way, that should include so-called alternate medicine too, which I know personally and I know from all kinds of experiences works. So, but there's a kind of snob element. I challenged 2 deans of medicine within a few weeks of each other about homeopathy, and it was interesting how they both reacted in the same way. The first word out of both their mouths was placebo. Okay, placebo. But I had had an acupuncture treatment that had a dramatic effect, and I also had a cortisone treatment for a Bell's palsy earlier that had no effect. Now, why wasn't the cortisone treatment a placebo? How come acupuncture was the placebo in that case? Okay. The second thing out of their mouths was herbal medicine, which is quite interesting because homeopathy is not about herbal. They didn't know what it was, and yet they were putting it down. They didn't know that it's not a fundamentally herbal the way naturopathy is. So there's that kind of snob element that we've got to get past. And this idea that a physician becomes director of clinical services and therefore is no longer a physician in the eyes of his colleagues is you know, it's a common attitude.
We have medical directors here that haven't distinguished themselves in many cases where we've had quality issues. On the team issue, let's just talk about Sam's teams. You know, I argue that what we have in the health service is rarely a team. We have a lot of people in the same room trying to sort something out, but if you think about teams, just think about a football team. I just use a soccer analogy here. If you take Manchester United as a football team, they will train on Monday and Tuesday and Wednesday and Thursday and Friday. They'll play on Saturday and have a day off on Sunday, or they'll play a midweek game or what have you. But my point is they will take longer training to play a game than they actually play a game. The game is only 90 minutes, but they've spent 7 days or 5 days training for 90 minutes. It's the same in the military. They will train for years and years and years, and perhaps only spend a brief time in the front line killing the people they've been trained to kill. Yeah. And yet we put together in the same room a geriatrician, a podiatrist, a manager and a district nurse and a blah, 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 and all of a sudden they're a multidisciplinary community bunion team. Actually, they're not. No. These are just people who have been thrown together. We don't spend enough time letting people become teams.
Absolutely. But you know, baseball is a better metaphor for healthcare than soccer or football, because in baseball, what you've got are 9 people who are doing 9 completely different things, and their coordination is all automatic. A double play, which is an exotic form of baseball, is 100% programmed. Just as an operating room, where an operation can run for 5 hours, and the surgeon and the anesthetist don't exchange a single word in 5 hours. They know exactly what to expect of each other. And that's the great strength of healthcare and the debilitating weakness of healthcare. It's the great strength because healthcare is mostly about getting you as a patient into their category. So you got a pain in your right side, good, and it's an appendix attack, terrific, everybody knows what to do, they get on with it, they take out your appendix, the government or the insurance company ticks a box, pays the hospital, whoever is getting paid, and everybody's happy. That's when the healthcare system works wonderfully well. Where its debilitating weakness comes from the same structure, which is they don't communicate with each other very well. And even when they're coordinating, like in an operating room, they're not interacting. They're simply reacting to what they know the other's about to do. there are three problems with that. The first are conditions that don't fit into a category. You've got IBS, or you've got some kind of autoimmune disease that medicine hasn't gotten around to looking at, or whatever it is, and sorry, you know, maybe you find an alternate practitioner, but medicine won't help you. The second are the geriatric cases, for example, where your problems cut across several categories and they have to talk to each other. But they don't. They scribble a few words on a piece of paper, send it to the other person, they get a few words scribbled back. That's not problem solving when it's difficult. The third is the most interesting of all, which is seeing the person beneath the patient, which Sam was sort of referring to, that you deal with the person beneath the patient. And there's a very famous article called The Bell Curve, which I advise everybody to read, by a guy named Atul Gawande in New Yorker, where he looked at a cystic fibrosis physician who had developed all the protocols that everybody was using, and yet nobody could get the performance that he got. And they were all using his protocols. They were all doing the same thing, supposedly. And Gawande went to observe, and he was treating a young woman, and some reading was a bit low, and he said, "Are you doing your exercises?" And she said, "Yes." And he turned to Gawande and he said, "Well, that's good, because if she doesn't, she'll take several years off her life." At this point, she broke down and admitted that she had a new boyfriend and she didn't know how to fit the exercises in. And he said, "Good, let's sit down and talk about it. We'll figure out a way for you to do your exercise." He saw the person beneath the patient. He wasn't treating the patient, he was treating the person and her boyfriend and her situation. Okay, and he was running over time, right? I mean, I don't know if he was controlled that way, probably too prestigious, but he was taking too long with that patient. And what's the payoff for taking too long with that patient? The fact that she's going to live 5 years longer and 20 years from now? Go measure that. He'll be gone, she'll be gone, and everybody in the hospital will probably be gone by that point. So the whole system is stacked against the fact that he was doing proper care, proper treatment.
Jenny,
Would you like me to stand up? It doesn't
would you
feel
mind?
the
Yeah, it's
difference.
just we can get you on the microphone better. Yes.
I'm really, really interested in your thoughts about developing and educating people to be brilliant managers. And they may be doctors, managers, nurses, whoever. If tomorrow you were given a remit and an unlimited budget, how would you educate and develop brilliant managers in the NHS?
I love that question. Where's Sheila? You want to answer it? I love that question because we've done it. And we didn't need an unlimited budget at all. We actually have a very small budget. We have a program called the International Masters for Health Leadership, which is hugely popular from those who know it. I don't want to make a promotion here. Of course I do. But
Oh, please do. We've got an international audience.
IMHL.org. And it's built on a business program we developed called the International Masters for Practicing Management, IMPM.org. And basically we threw most of the rules away, although some of these practices were common in the UK, in England, but not much elsewhere. And that is flat room, round tables, people with experience. We don't accept would-be managers. We want people who are in managerial activities that can bring their experience to the classroom. Half the class time is devoted to them, sharing their experience, reflecting on their experience, and sharing it with each other. And then we do all kinds of things like that. So we have managerial exchanges where they spend the better part of a week observing each other. Even people doing the same job in 2 different countries get enormous benefit. But if you get somebody in public health observing somebody in community health or whatever, it's very revealing. So we do all kinds. We do what's called friendly consulting, where they come with a particular issue and their colleagues act as their consultants and help them think through their issues. It's so easy. It's so easy. It doesn't take unlimited budget at all. I mean, we have fees for the program, but they're not outrageous. And we let them do so much of the educating. And I always joke that we should pay them because we learn as faculty as much as they learn. And so look up the details of the program on imhl.org. Not necessarily to come to it, I mean, we welcome you, but to see the kinds of things we do in that classroom. It's quite remarkable.
There was a lady, yeah. Can I do the lady behind you, sir, and then I'll do the gentleman in the yellow shirt. You probably want to get a bit closer.
Yeah.
Yes. Yeah.
I too disagree with the gentleman at the back.
Leave him alone, will you?
I don't recognise the leadership and management that you were talking about. I recognise that you're talking about an acute organisation.
No, I've worked in all systems. So I've
still
worked
don't
in primary
recognise it.
community.
Oh, well, let's get to the question before you have a
I
row.
would be interested in your thought around culture within an organisation supporting leadership and management. My organisation, which is a community-based organisation, aligned to the NHS, our more senior team, and I'm talking about
Top.
exec, well, you can't have that structure. So the people at the top, they go out regularly with the teams on the ground. Our chief exec last week went out with one of our community patrons and saw a patient who was the epitome of somebody who we should be supporting and helping. It wasn't a designed visit, it just happened, and it was very, very powerful. But I think the culture in our organisation is correct to allow her to do that, for her to understand, what our staff are dealing with on a daily basis and how they can help. But I personally think that's to do with culture that affects leadership and management. I'd be interested in
Yeah, well, I mean, it's a great story.
Can you come back, Henry,
Yes,
please?
sorry.
We just need to capture on
Can I
so that
If
folks at home can hear you.
I
Thank
think
you.
the role of culture, I think it's a great story about a community organization that really is a community organization, and you hear stories of that all the time. I have trouble distinguishing culture from communityship. To me, they're almost synonyms. So when I say communityship and you say culture, I think we're saying the same thing. We're saying that people are engaged, they care, they love going to work, they're respected, the organization respects them, there's a strong feeling about things, and above all, healthcare is not a business, it's a calling. And for people who act like that, it's a calling. The thing that strikes me about our IMHL program, and the people who come to it, and they come from all over the world in all aspects of healthcare, the thing that strikes me is how many of them, and I'm talking almost all of them, are there for healthcare. It's amazing. They're not there, they're not just there to develop themselves. Of course they're coming to be there. And of course they're coming for their organizations. But they are devoted to healthcare. So when somebody from Colombia is talking to somebody from Iceland, they're sharing their knowledge of this calling called healthcare. Or if they're dealing with somebody who has come from Timbuktu, from what's the country? Anyway, from Timbuktu.
Zanzibar.
No, not Zanzibar.
That's a good country.
Yeah, no, but it's not where Timbuktu is.
Oh,
Ethiopia.
Ethiopia.
I think it's Ethiopia, isn't it? Anyway. Okay, Mali.
You get geography as well.
But we have some current students from Ethiopia. And if somebody's coming from Ethiopia, the rest of the class are really concerned not only with helping that person deal with different kinds of problems, but learning from them, because if they do a managerial exchange with somebody in Ethiopia, they're seeing things that are going to affect how they see their own work when they get back home.
There's an
So
organisation called the European something or other of health management, and when they get together, it's really interesting how they share their problems. Just carrying on from your question, Henry, let's think about that organisation, right? What do you say we reorganise it? I know you hate reorganising it, but supposing we said, okay, well, look, for governance purposes, we've got to have somebody who is in charge. Mm-hmm. For good governance purposes, we've got to have a finance director because somebody's got to sign the checks and all that. And what do we say? This is a community organisation. It's disparate. Why don't you say we just have self-managed teams? They make their own decisions, and it doesn't take the boss then to get out from behind the desk and come and find out what Gladys is doing at number 57 at Casey Avenue and make a decision that Gladys can't make. Why don't we just make Gladys make the decisions? And if that sounds bizarre, and if it sounds too much, actually they're doing it in Holland. It's called birdsong. Yeah. You know, so we don't have to have this. I mean, I think when I hear of an organisation that can't make a decision unless through serendipity the chief executive gets off his backside and ends up in somebody's sitting room, the organisation is the wrong organisation. discuss.
Yeah, well, of course, you're describing how medicine works anyway.
Yeah.
Nobody's coming into the operating room and saying, you know, cut a little lower, please, you know. The pressures are about cost and all those things, but for all the professionals.
But self-managed teams can manage budgets.
Yeah, no question, and they should be managing. You know, the big payoff is when they start to interact with each other in an intense way, so they understand each other's problems. You know, organization, meaning division of labor, is necessary, and division of labor includes management, because part of what management does has nothing to do with control. It has to do with external liaison. So somebody is funding the place, so the manager is someone who is in touch with the person funding the place to make sure that support continues. So it's all division of labor. But whether you view management as fundamentally control, you know, planning, the classic description of managing is planning, organizing, coordinating, commanding, and controlling from Henri Fayol, 1916. Well, that's 5 words for controlling. And there's a lot more to managing than controlling. There may be a need in some cases for controlling.
Well, we've seen, I mean, Sam is the head of our innovations, and we call them vanguards here. I don't know if you're familiar with that, but fundamentally it's people kind of taking ownership of their local problems and sorting themselves out. And there it's the ownership of the problem. And where they've been freed up to make decisions, invariably they make good decisions, which we're trying to replicate across the rest of the NHS. The difficulty is the replication and what we call diffusion, which doesn't really exist. There's a gentleman, I hope you agree with that.
These are intelligent professionals.
Yeah.
They know how to think. And distributed management is a word that appears in my book too. About,
yes, I know.
And strategy is, you know, if you look at strategy in a hospital, strategy is not, a general hospital has no strategy other than geographic location. It's doing what every other general hospital does in a particular location. Well, Michael Porter doesn't like that, so he thinks they have to have strategies, therefore they should specialize. Well, specialize so that, so we have an emergency case and we're going to ship it 300 miles away because that's where the emergency specialized hospital is?
Well, that's what we're doing. I mean, we're doing that now. And it's interesting because if you take, for example, our right here in London, we've got, if you had a stroke in London, you know, if you, just recently, really, you'd end up in A&E where you'd be seen by a junior doctor who probably didn't know, they'd never seen a stroke before, and you could die. Now they go to a stroke unit where we've coalesced the excellence of the skills of the clinicians to deal with stroke, but that was driven really by the money as much as it was driven for the pursuit of excellence. Yeah,
but you've also, you know, it's not about specialization of hospitals, it's about specialization of services.
Yes.
And that's a different story. Within a geographic region, you can do that. You can't do that if you've got small towns spread out unless you can bring in some electronic way to do it. So we've got to be kind of careful.
It's interesting what you said about strategy. I've given up on that. Yeah. I know you've given up on strategy.
No, I haven't. No, not at all. But what I'm saying is the strategy. You know, there's a Montreal hospital where somebody, a pulmonologist, was big on building a center in that hospital for better lung treatments, and it's become quite renowned. And the reason that hospital has that is because one person championed it. And hospitals like universities are collections of things that people have championed. The IMHL program at McGill University is there because some people at McGill championed it. And so the principal McGill didn't decide on that. It was championed. And we're the sum total of all these things. Strategy in a university or in a hospital like a university is the sum total of all these initiatives. And that means it's ground up, it's distributed.
It's tactics and techniques. Gentleman in a yellow shirt.
A couple of points I'd like to make in a question. I mean, I've tried to do your MBA and make a business case to the NHS to free me up to do it. And whilst I recognise the fees are eye-watering, the finance directors and the accountants think they are eye-watering. They want a business case that proves that I will deliver certain outcomes based on a certain set of inputs that looks very logical, positivist model. And this links, I think, to what we're talking about with self-managed teams, what we're talking about distributed leadership. We know it will work close to the point of delivery. Where it won't work is in the political decision-making spaces, where it won't be allowed to work. So how do we get the, I guess, the scientists and the craftsmen, and it is largely men, who are running the health service at the political levels, to give us the space to do what we need to do to practice the art of good healthcare?
Well, you know, that wait till I get another camera. That needs a lot of rethinking in terms of politics. I don't think Churchill said that, you know, democracy is the worst possible system except for all the alternatives, but it doesn't have to be that bad, and it doesn't have to be dysfunctional. It doesn't have to be so dysfunctional where people who are quite ignorant often, and I won't mention Donald Trump in this sentence, people who are quite ignorant get to make major decisions. And it's like saying, how can America possibly get past Donald Trump? I think it's the same question. And the answer is by waking up, by realizing, by coming to its senses. What else can I say? But let me distinguish, a little joke to distinguish medicine from management. I saw a cartoon that showed a bunch of surgeons around a patient, and the line was, who opens? Kind of like in bridge, right? Who opens? And it was a kind of humorous thing. But in management, that's a real issue. In management, who opens is a real issue. Because in medicine, every time you see a patient, you make a conscious decision. Every single time. If it's to do nothing, that's a conscious decision. We'll watch it, come back in a month. It's a conscious decision. In management, and when it comes to an operating room, we know who opens, and we know who does what exactly. When it comes to management, who opens is a big part of the issue, because is there a decision to be made here? Is there a problem here? Is this too early? Is this too late? You know, how do we get together? What do we do? That's why management is so different from medicine.
We've had a really interesting example, really, in the NHS recently. I mean, all the time I've been in the NHS, the chief executive of the NHS has been compliant with the political requirement of the time and the political policies of the time and the latest change and the latest vision that they've got for politics. Except this time with Simon Stevens. Now Simon has driven the political agenda, there's no question about it. He's survived a row over the money with Downing Street because he was right, and he's survived as long as he has survived because he has been right. And because he has delivered. He's not actually delivered that much, if you look at it, but you can see what it is going to deliver. He needs longer to deliver. So we've had an interesting set of circumstances which has turned the whole dynamic on its head, I think. The paradigm has changed because we've actually got a chief executive who's driven the politics. Yeah. And I'm not sure quite how that's happened, and I guess we'll reflect on it and figure it out. But it is, you'll meet him tomorrow, but he is a really interesting guy.
But there are other ways to have single-payer systems, what's called single-payer systems, right? It doesn't have to be the government. Kaiser Permanente is a single-payer system, and they can look at the problem systematically, and they don't have the politics to deal with because they collect their money from their members, all of whom are covered, and so on and so forth. So there are other ways to do it. In Canada, well, I can't talk about Quebec healthcare in this regard because the politician screwing it up something awful. But CBC, for example, is state-owned like BBC, but untouchable. I think relatively untouchable, and it is amazing. CBC radio is like amazingly good, and it's untouchable by the politicians. So you can have state agencies that are at arm's length. And you can have a board, as the CBC has a board, instead of letting it come under the whims of the politicians. If one politician was brave enough at some point to cut it off and say, we'll set it up in such a way that a responsible board can oversee this, then you might get something.
Well, interesting, the Lansley reforms tried to do that. It divorced the NHS England, which is the operational arm of the health service, from the Department of Health. And they're supposed to manage through an annual mandate, which is kind of a list of things to do. It hasn't worked, but the philosophy behind it, I thought, was a bit like putting the Bank of England in, the what's it called, the Bank of England, whatever it is, committee, monetary committee.
Run by a proper Canadian.
Run by a proper Canadian. I bumped into.
I just want to mention that the trusts, the movement
to move the hospitals towards trust status is a bit the same thing.
Yeah.
At the hospital level.
Yeah, we tried to make them freestanding and separate, but the brand got damaged really over the money. Look, I'm very conscious of the time. We've only got 6 minutes left, and I know I've promised to do all the questions. So what I'm going to do is, who did I promise next? It was you, wasn't it? And then there's, I think there was a lady there. You've been waiting as well. So I'm going to go to this lady here, then you, and then the lady in that corner. I think that'll have to be the last question. So it better be a good question when you answer the last one, because we've waited all evening for this. Anyway, we're over here. So would you mind standing up, please?
Hello, Henry. I don't want to misquote you, but I think I read somewhere that you said that health should not be seen as a commodity, and therefore the whole concept of running it like a business. So I'm interested in your views about if we create it as a business, we get some of the management stuff that people are talking about and some of the behaviours that go on, which we say are dysfunctional and not helping improve people's health.
Okay, just while you're coming back, the question is, if you didn't hear that at home, is that can the NHS be run, or health services, healthcare really, be run like a business?
And commodity, and the idea of commodity. I spent some time in the book talking about categorization, commodification, and calculation. And my argument, in fact, it's a piece near what Porter writes about. Porter would disagree with this completely, but he's about categorization, commodification, which he would deny especially, but especially calculation. That's his bottom line. You categorize and you commodify in order to calculate, and that's not just Michael Porter. That's across the entire system.
Porter was a man of his time, though, wasn't he? Don't you think? I mean, he was one of the very early thinkers about management. He formed his view through a lens of a certain period.
Oh, his first book on strategy is fantastic.
Yes.
It's an amazing book. It's his healthcare stuff I had trouble with.
Yeah.
And
what about Deming?
What's
Edwards Deming.
Well, that's going farther back.
Yeah.
Yeah. Yeah. I mean, we can get to that, but let me just address this first of all. The
Commodification.
They all do it. They all do it. It's not just administrators do it, or analysts like Porter, or economists like Porter who do it. Physicians do it. I mean, the whole medical practice is based, and insurance companies do it, and governments do it. It's all based on categorization, commodification, and calculation. And as I said earlier, that's fine when you fit the categories. But when you don't fit the categories, then, you know, when you're across the categories or beyond the categories or beneath the categories, then it doesn't work and it becomes dysfunctional. So we have to do both. You know, my feeling, just to talk about something different very, very briefly, is my feeling about globalization after Brexit is so many people are for or against globalization, whereas everybody should be for and against globalization. There's positive benefits to globalization, there's negative benefits to globalization. It's not all for or against Brexit. The same thing with healthcare. That the calculation, commodification, and all that is vitally important for much of what the field does and for many of its worst failures at the same time.
I think that's a great answer. It's before both of it, because there's no question about it. I mean, in the commercial sector, competition levers quality and price, and we have a lot to learn. In the health sector, we've tried competition. It's been a failure, really, here, because we haven't got a proper competitive market. So, but there's a lot to learn from both. I think it's a great answer. Thank you for that question. Can I move you on?
Yeah, just very quickly.
Yeah.
What we need, we have too much competition in healthcare, but it's not market competition. It's competition for beds and competition for budgets.
Yeah.
And we need more cooperation.
It all comes back to the money. Yes, ma'am. Fire away, please. Yes, would you mind, so we can all hear?
Yeah, sure. Yeah, my question is about regulation. Very interested in what you said about community and encouraging best practice, because it feels sometimes like regulators were trying to move from, you know, just being about, you know, telling whoever off, to working closer with people and moving into community, but are uncomfortable with that. We haven't worked it out yet. So, would you say that what's the best thing for us to do? Should we assume, like you say, that best practice is just kind of inherent and we need to focus on removing the barriers to that, or?
Wait, say that again. I want to make sure I get the better practice.
When you talk about best practice as being something that you can't necessarily teach, but is kind of just there.
Yeah.
Should we, as regulators, think about it as people who want to work in healthcare and in management are doing it because they want to help people? Therefore, the best thing we can do as regulators is to get rid of some of the barriers, rather than try and do what I think we're trying to do, is saying we know what best practice is, and we can...
Yeah, I'm glad you answered that question, because I have a few things to say about that kind of thing. I'm not a fan of best practice per se, and I don't think anybody should try and be the best, because being the best means trying to be a little better than somebody who's designated the best, and it means you're aspiring to somebody. I think everybody has to do their best, and each person has to do the best that they can possibly do. And their target should be, how can I get better and better, and not how can I match so-and-so. That's a competitive kind of mindset that I don't think is as functional as a mindset that says, I'm competing with myself to get better every day. And the best people, Michael Porter didn't compete with anybody when he wrote his great books. He didn't compete with anybody, he did his best. And that's terrific, that's what we have to do. And you're back to, I think, healthcare is a calling. It's a calling, it's not a business. It's not about competition. It's about serving in the best way you possibly can.
Right, last question, man, if you wouldn't mind standing up.
Yeah. I'm really looking forward to reading your book, so that's great. I first read your work when I had light hair, and you probably had a bit more hair. So a long, long time ago, back in the 80s. Who do you read?
To me, that's a short time.
Yeah. Who do you read, and who do you recommend we look at? Who are the new thinkers that are coming into your shoes?
You know, somebody said you can read or you can write. You can't do both. I happen to like sometimes people like Gowande, who write amazing stuff in the New Yorker on healthcare. Well, people like Malcolm Gladwell, who doesn't necessarily do that much on healthcare, but has quite interesting things to say. What I'm reading in general, I'm reading a history biography of Tchaikovsky now.
Oh, great.
Find out how somebody who could put together such amazing music, what his life was like. So, I mean, that's what I'm reading now. It's more articles and things than books, although I cite a number of books from this country about the NHS and about other aspects of healthcare in my book. So I try and read as much as possible. You can never read enough because somebody's always going to say, but you haven't read this or you haven't read that. And
some of the companies are interesting, aren't they? The way Harvard Business Review, for example, will often highlight a company. I read an article just recently from a company called SumAll, which is a data harvesting organisation that gives you your footprint on social media. And the guy that's running that, he's got a terrific approach where people elect their bosses, which I wrote about, some of you will know, just recently. And I thought, you know, that's I like the idea of that. I used to run services for people with learning disability, and we had them on the recruitment panels when people came for a job, so they had a say in who looked after them. And I think, you know, those kind of approaches really, that I'm not sure there are the great gurus anymore. I think what's coming from it's worth watching the startups, I think, and their different approaches.
You know, there was a book by Ricardo Semler years ago called Maverick.
That's right.
And a number of Harvard Business Review, where not only electing bosses, I don't know if they actually did that, but they were doing all kinds of seemingly crazy things. So maybe let me say something constructive in that light. If we want to improve the selection of managers, and we make so many awful mistakes, we need to get the input of the people who know the candidates best. And superiors or board members or politicians or outsiders do not know the candidates at all because they don't know how they manage. The people who know them best are the people who have managed, who they have managed. If you really want to know someone's faults, because every time you're picking someone for a managerial job, no matter how junior or senior, you should be picking them as much for their faults as for their strengths, because it's the faults that are going to undermine them if they're fatal. Everybody's got faults, I'm sorry, even you, right? I'm sorry to have to say it.
Steady on.
But we have to pick people for their faults as well as their strengths. And how do you know someone's fault? There's only two ways to know someone's fault. Either you work for them or you marry them. Now, if you're picking managers, you can't ask the spouse because you're not going to get an objective response. You can't ask the ex-spouse because you'll get an even less objective response. But you can ask the people who they manage. That doesn't mean you let them elect the managers, but it means you get the voice of people who know how they really manage. And we don't do that very much. There is one company that elects its chief executive, and it's been the top company in its field for decades. And it's McKinsey and Company.
I think Deloitte's do as well.
There's probably a number of them do
Yeah.
the same. Yeah. And McKinsey and other companies like that, some of them, they elect, the partners elect the chief executive. And they've been doing great with it. I don't think they ever recommended it to any of their clients. I don't know if Deloitte has recommended it to any of its clients.
Ouch.
But it's not a bad idea.
Listen, we're over time, and I'm going to give you the last word. NHS, what do you think?
The NHS has always been a really interesting organization, and it's kind of, you know, there's two sides to the NHS. There's brilliant pockets and innovative ideas and all kinds of wonderful things that go on, and there's a lot of shtick in the NHS, a lot of things, excess reorganization, excess measurement, disconnected management. You know, I have a recommendation for you. Get rid of the label Chief Executive Officer. It's a business term that means I'm in charge and I'm the boss. And the first thing you can do in the NHS is delete that term forevermore. Because it makes it sound like a business, and people start running around. I've heard this often up talking about my hospital and my region or district or whatever's fashionable this week. And I think that the NHS has to be purged of this business vocabulary. Frankly, it's not a business.
Well, I should just let you all into a secret that we're taking Henry to see Simon Stevens for half an hour tomorrow, because Simon insisted that Henry wouldn't be allowed to leave the country until he'd had half an hour. So it will be really very interesting to see if he ends on the theme that he's ending with us tonight. Have you had a great evening?
Yes.
Yeah. Thank you very much. Regulars will know that we always give our guests a very special gift. We've got a special gift for you, Henry. You'll probably think we're balmy. It's a bottle of whiskey, but it's very special whiskey. It's whiskey that's made in Wales. And it is the best whiskey in the world. I'm sorry to anybody listening in Scotland. It's the best whiskey in the world. And I know you sometimes are kind enough to read my stuff. I almost never touch a keyboard without a glass of pen. Okay, but we've had a fantastic evening. Thank you for your wisdom and your time. Thank you very much. Okay, you've all got a book. I tell you what we'll do.
Why doesn't everybody come up and get the book?
Yeah.
And then if Henry stays there, we kind of...
Yes, I'm sure Henry won't mind writing...
flow.
Hello. His phone number in them. And if you'd like him to autograph, I'm sure he would. So it's taken a bit of time. So if you come down, grab a book, let's sort of form an orderly queue and then get a glass and we'll all have a nice evening. Thank you so much.
Oh, okay. No problem. I'm going to hang around.